All right, so let's get started. So as we always begin by just reviewing what we covered last week. So what are some of the highlights from last week's class?
We talked about market share and talked about possible reasons why market share would increase or decrease over a certain year period.
Mm-hmm. Mm-hmm. Okay.
We also made a pro forma,
Yeah.
similar to what an organization would do.
Okay. And what is a pro forma?
It's like a financial forecast, and it provides like an outlook of the financial future of an organization.
Hey, let me show you to introduce you guys to my 8-month-old. Okay. Say hello, Carter. This is Carter. Uh-oh, sorry. Let me do this. This may be easier. So you guys can see the little fella. This is my pandemic puppy. All right, let's see. Okay, there we go. Say hello. He's a golden doodle, a mini golden doodle.
He's so cute.
I
how
love
many how many pounds is he?
He's 25 pounds right now.
Oh wow.
I love his color. I've never seen a golden doodle that deep. He's so cute.
Yeah, it's so interesting because people ask us, they say, "Is he? Did you all color him?" And I'm like, "No, this is natural. I would never do that."
Some people
Yeah,
do.
they call it ginger.
Yeah. Okay.
Yeah, it's ginger.
Oh, he's so
Yeah.
fluffy.
He's very calm, very chill, very
Love
lovable.
his head, the top of his head. Can you touch
Yeah.
the top of his
Oh
head?
yeah. It's a
Oh,
it's a little fro, a little
love
mohawk, a little like a
I
little
love
mohawk. Yeah. Yeah. Yeah.
sweetie pie.
All right, buddy. Time to go to work.
Do you know how big he's gonna get?
Just a few more pounds.
Okay.
Yeah, just a few more pounds. All right. Okay. I usually leave the virtual background up so that you won't see him in the background, but I'll see how this works. I know he can sometimes be distracting. All right. So what's a pro forma?
I said that it was a financial
Yes,
forecast.
you did say that.
Yeah.
Sorry, Michelle. Okay. So it's a financial forecast. And last week you went through an exercise where you just used your own life to develop a pro forma. And why is that an important skill for you to have in a strategic planning class? Why am I teaching you about pro formas and strategic planning?
With a pro forma, you can help to kind of forecast what your costs for the organization may be and like how to control for things. So it's important to know like kind of what it may be in a year or 2 years and what factors will affect that.
Absolutely. So if you are planning to construct something new, add a new service line, hire new people, you certainly need to have some type of financial plan to show how you're going to make that happen. And the pro forma is the tool that allows you to do that. Okay. And we talked about a variance. So what is a variance? What's
Is
a
it the
variance?
difference between years?
Keep going.
Um, so for example, the variance, if one year you spend like $10,000 on something and you spend like $20,000 the next year, the variance would be $10,000.
Right, right, right. Well, it's an anomaly, right? So let's say over time you stay in this range, and then for one period of time it just spikes in one way or the other, right? Up or down. And you're just like, wait a minute, what happened during that time period? Right? That's a variance. Okay, so it could be annual, it could be quarterly, depending on how frequently you're managing or looking at whatever it is that you're analyzing over time, right? So anything that's kind of spikes in one direction, um, either up or down, you naturally need to have a note in your forecast because folks will want to understand like what happened in November, right? What happened in November? And then sometimes you have seasonality, right? You're familiar with the term seasonality, like some things happen and seasons, right? We know that you know, during some times of the year, we're more likely to see ER visits. You know, more people are in the ER, right? So we call that seasonality. So you may have seasonal trends in utilization. We also talked about fixed costs versus variable costs. What's the difference?
Fixed costs remain the same each term, and then variable costs change each
Right.
term.
Right. Okay. All right. What else? From last week. So I think we went into bond ratings and market share, and I gave you the different, I showed you the pyramid, right? And the different ways that bonds are actually graded, right? And so what is a bond rating and why is that important?
I think it was important because it had to do with the likelihood of a business getting a loan, and it was. I think you said it was somewhat similar to credit scores and how individuals can get loans with like a better credit score. They have more credit options.
Right. So they have I'm really sorry. I think I may have to put him upstairs. You all can hear that background noise, right? You don't hear anything? Okay. So the bond rating is your ability to secure low interest loans, right? That allow you to reinvest in your organization. And that's what we see happening in a not-for-profit, right, organization. So large health systems, many of them are not-for-profits, like MedStar, it's a not-for-profit, $6 billion not-for-profit. And some people have a difficult time wrapping their brains around that, right? Like, how are you going to be a not-for-profit at $6 billion? Well, all that means is that your profit is going back into your enterprise, right? You're not using your profit to pay inflated salaries. You're not using your profit to purchase private jets for your leadership team and for your folks to go have luxury, you know, extravagant retreats in different parts of the world. That is inappropriate for a not-for-profit. You see that happening in the for-profit space, though. That's very normal. Okay. But don't be misled. We still have to pay competitive salaries, right? And so the CEO of a $6 billion enterprise is going to have a compensation package that reflects what you would see typically in someone who's managing, or the CEO of a $6 billion enterprise. And that could be up to $1 million that this person's getting paid. So you have to go by the comps, right? And go by what the market is paying. And typically that's based on the budget size, the size of the budget. The more budget that you're responsible for, the higher your salary is likely to be, because it's a big responsibility that requires a lot of skill and talent and experience. And so people should be paid accordingly. Okay. All right, and then market share. We talked about market share, and I gave you some data, and you were able to play around with different service lines and you also looked at the health insurance plans in California, right? You looked at those last week, and you were able to ask some questions based on the trends that you saw. Again, that's what planning analysts do, right? They look at data and present what they're finding to their leaders, and their leaders are able to make much more informed decisions about the future and what they want to invest in moving forward, how they want to grow and be strategic and be distinguishable in the market. Okay. So we are almost at the midpoint of this class, and we change gears, right? We go from the planning to the marketing, but there's another piece that I want to be sure that I cover. I think it's important as we think about planning my work and my scholarship is around racial equity, health equity, and how do we create systems that work for all people, um, with a special focus for me on historically marginalized communities of color. And so what I'm going to do for this class is share um, some insight on how we can plan and make sure that the work and all the decisions that we're making are all inclusive and that we are really reflecting the diversity of the patient populations that we're serving. We can't afford not to do it. We truly cannot afford not to do it. What we're doing right now is not working. And what we've observed in this country over the past few years just shows that we really have some serious issues that we need to reckon with. We have to reckon with our history, and we have to know our history, and we have to conduct critical audits of how we do business and and identify the norms and the practices and the policies that continue to disenfranchise, marginalize people, leading to poor health outcomes. So I have two slide decks I'm going to run through fairly quickly. One is just on creating equitable systems of care, and then the other is on implicit bias. Okay. But I want to start by sharing a video that was produced by one of my students. Um, and it's just 5 minutes, but I think it's a great way just to start this lecture. All right. So let me share my screen. Okay.
For some, it's harder than others.
This is
Healthcare in America is a complex, fragmented system that can be extremely difficult to navigate. For some, it's harder than others.
this is Shonda, a 50-year-old Black woman living in a low-income neighborhood in the inner city. She has diabetes and hypertension, but tries to stay as on top of it as she can. One day, Shonda wakes up with a bad cough, a side effect of the Ramipril medication she is on. It was manageable for the past couple days, but now it has gotten a lot worse. She was planning to go for a walk around her neighborhood to get some exercise in, but is no longer feeling physically up for it. Fortunately, Shonda remembers that she has a doctor's appointment later that day. Because of some policy change, her former doctor no longer accepted Medicaid, so it's the first time she'll be meeting with her new doctor. She makes a mental note to ask her doctor about the intensity of her cough. Just like every day, Shonda gets dressed for work early in the morning and walks the nearest bus stop, which happens to be about 15 minutes away from her home. The bus ride is another 10 minutes to the metro station, where Shonda takes a 30-minute metro ride to get to the neighborhood she works in. Shonda is a home health aide, and the home she works at is a 10-minute walk from the metro station. Today, especially, is a harder day to work because of the cough. Instead of working from 8 a.m. to 6 p.m., as she would a typical day, she works until 1 p.m. so that she can make her appointment. Of course, in order to take the time off, Shonda had to work a double shift last week. At 1, Shonda changes, leaves from work, and waits for the bus to take her to a stop that is a 10-minute walk away from her doctor's office. Finally, she arrives at the office and is told by the receptionist to have a seat in the waiting room. As she sits and starts to observe the office, though, she starts to feel uneasy. She knows the physician she is seeing today is a white male physician, but all the doctors on the wall are also white doctors. She starts to look through the brochures laid out on the table, but realizes that she doesn't understand some of the conditions that are written. What's more, all of the patients shown in the brochures are white. She wonders, why is there no one here that looks like me? At last, Shonda is called in to see the doctor. Right away, he starts talking to Shonda about her medical problems. Shonda is taken aback that he does not introduce himself and is overwhelmed by the speed at which he is talking. He lectures her on the importance of healthy eating, especially for someone with diabetes, and tells her to eat more fruits and vegetables. He keeps talking about how she needs to be more proactive with her health in order to avoid even more expensive treatments later on. Shonda quietly nods, but is reserved. She knows that the nearest grocery store selling healthy foods is 40 minutes away from her home. The cheapest food available is from nearby fast food restaurants, and her local grocery store is primarily a liquor store. She thinks to herself, does my doctor think I don't care about my own health? Finally, the doctor tells Shonda that hypertension and diabetes are risk factors for eye disease and that she will need to start following up with an ophthalmologist at least on a yearly basis. He writes down the name and address of a referral and hands it to Shonda, but she sighs. The specialist is located more than an hour away from her home. She then immediately asks if that doctor takes Medicaid. The doctor thinks for a second, says he doesn't know, and before Shonda could say anything else, he opens the door and shouts to the nurse down the hall if she knows whether the ophthalmologist takes Medicaid patients. Shonda blushes. She's embarrassed that her personal information was displayed so insensitively to the whole office. As Shonda leaves the office, she is charged a copay for her visit. As she begins her long commute back home, she realizes that she forgot to ask the doctor about her cough. Looks like she'll just have to tough this one out.
It's important to understand that although Shonda's story is fictitious, it accurately depicts struggles that many Black and Brown people in America face in the healthcare field. As healthcare professionals, it is our duty to understand the nuances and backgrounds of each patient to reduce the inequities faced by minority communities. As we remember Shonda's story and the story of countless others, we must keep these questions in mind. What was it about Shonda's healthcare experience that showed the lack of empathy or cultural humility? What was it about the design of the healthcare system that may have perpetuated or normalized the provider's behavior? What could have been done differently?
I'm going to leave these questions up for us. Can you hear me okay? I'm not using my headphones. Sometimes it's difficult. You can't hear me, Rachel?
It's a little hard to hear you.
Okay, so I'm going to leave these questions up for us. First, just your reactions to the video. Again, this was produced by a sophomore.
I can't hear you too well.
Okay, now can you hear me? Is this better?
Yes,
A little?
thank you.
Yes.
Okay, so this was produced by a sophomore who's taking a class that I teach on racial equity in healthcare, and what the students are responsible for doing is helping create videos and infographics to help other students actually think through these issues. And so this was a product that he produced that I'm using for other students. So just wanted to get your reactions to it. And there's some probing questions here for us.
I thought it was really well done, and it showed like the intersectionality of like her socioeconomic status, her race, and like how that affected her experience when she was trying to get care. Because I think that a lot of research or like people when they think about like healthcare access issues, they're thinking about like one identity. So like a individual who's low income or an individual who's Black, but it's like the combination of identities that really contributes to people's experiences.
Yeah, absolutely. Great job, Rachel. Anyone else?
I think it was interesting. They brought up like lack of food insecurity and lack of healthy food options in the area. So that like addresses the issue of like food deserts and living in them and how that can cause negative health outcomes.
Yeah.
I like how they combined a lot of social determinants of health from, like she just said, food, but also transportation, and then kind of like a dissonance and understanding between like the healthcare provider and the patient when it comes to those kinds of things that might affect someone's health. Like they said, like, does the doctor think I don't care about my health? That was a really interesting part.
Right. And that happens a lot. A lot of times you have providers that just go into their spiel about you got to eat right, you got to do this, you got to do this, and they don't take time to really hear about the patient and the patient's lived experience and the barriers that patients are facing and encountering. And they don't see significant improvements in their patients' outcomes because of those barriers. Others? Other reactions?
Yeah, I would share that, from like leadership or hiring standpoint, to just have a diverse staff is important in general, and just having different people that care for different patients. It just creates, more welcoming and a bond between the patient and provider, especially if that provider is serving like a specific population. It just helps to have diversity in that clinic.
Absolutely. Absolutely. And that's one thing we need to do in planning, right? We need to know our workforce and the diversity that we have in our workforce. So what we do is we always look at, people who are different races, different ethnicities, different religions, right? We take inventory of all of that. And then you do the same with your consumer base, right? You need to know who your consumer is, what types of consumers you're serving, and there needs to be some congruency there, right? There needs to be um, a reflection in both directions, and when we don't have that, then we have patients who are not likely to be as engaged in their care, um, because of it, because they just don't feel that they're a part of the system, and that's happened for way too long. And we also know that that increased risk of medical error because of communication barriers or cultural barriers. So when we have that diversity, we're less likely to have those blind spots, um, and we're more enlightened, right? So, okay. Anything else from the video you'd
I
like
like
to
how
share?
they touched on health literacy, like with the brochures,
Hmm.
that she couldn't understand like the symptoms and it wasn't in plain language.
Yeah, yeah, that happens a lot, and we know that plain language is important. And it's not just about the level of education. That's important to be a highly educated person, right? We want people to know and be able to read and be literate. But we also know that people who are highly educated still can have some health illiteracy. So just to make the playing ground even for all people, we really need to look at our materials and make sure that we are using plain language. We're staying away from colloquial language. We're just using plain language at, third, fourth, fifth grade reading level. And there are people who do this for a living. They will actually, you send them a document and they will convert it into plain language for your consumers. But that's really important. And we know that pictures, right, also can be helpful. Pictures and images and icons. And so there are marketing firms that this is what they specialize in, especially if you're working with populations that don't speak English as a primary language, or folks who are new to the country, right? So, okay. And that this is on YouTube if you're interested. So let me get out of this and pull up the slides. So this is based on work that we did in the District of Columbia. You have these are already in Canvas for you, okay? So if you want to follow along that way, you can do that. And then it's just my bio. And then these are just some publications. If you're interested in growing more and learning more in the space, here are some publications that I've either authored or co-authored that you may find interesting and helpful in your journey. And if you try and access something and you can't find it, just let me know and I'll get it to you. All right. So we're on a learning journey, right? I say that a lot. The nation, we started out talking about health disparities, which are measurable differences in health outcomes, and that language became socialized in our work in healthcare. And then we became a little more sophisticated and started using the language social determinants of health, recognizing that our health is mostly shaped by where we live, work, eat, and play. And then we began talking more about health equity and recognizing that everyone doesn't have the same level of opportunity. And because of that, we see differences in health outcomes. And now we are really getting to the crux. Finally, we are talking about systemic racism and how pervasive it is and the impact it's making, the negative impact it has on our country, the negative impact it has on productivity, the negative impact it has on health outcomes. And more importantly, the role that we have in undoing the damage as a healthcare industry. Every industry needs to go through this process, but we're talking about healthcare in this class. So, just a few assumptions very quickly. We're not living in a post-racial era. People thought that after we had our first black president, that oh gosh, we're all healed and kumbaya. Well, we've been shown that that's not the case. Hospitals and health systems contribute to racial disparities in healthcare outcomes, so we are part of the problem. Each of us has been born into an ecosystem that has been designed to treat people of color differently. Each of us has biases that influence our behaviors and our decision making. And clearly, Black and Brown people, as a result of our history, have a very complicated relationship with the institution of healthcare. So, in this country, we've done a really good job providing medical care. We are very medically centric. Prescribe medications, do the surgery, all that, we got that down. What we don't have, and where we have not cracked the code, is on prevention and really, truly delivering healthcare. All right. If we are delivering healthcare, then that means that we recognize that clinical care is only responsible for a small percent of our health status and the health of a population over time. So you can have the best clinical care in the world, meaning you have access to doctors, medication, and all those wonderful things. But if we're going back into communities that just don't have the infrastructure for healthy living, we don't do as well, right? And so we have to get to this space where we're recognizing, yes, the clinical care is a small piece, but what's happening in your home environment? What does your community look like? How can we use our voice as an industry to stimulate change in the structure of the community that is underserved or disenfranchised, right? That's healthcare. And we can't really have a meaningful constructive conversation until we recognize the power of systemic racism. You know, people come to work each and every day with the intent to do the right thing. I really personally believe that, especially in healthcare. People come to work, they want to provide the best care, make the right decisions, be the best managers that they can be. But the challenge is we are all swimming in a system that has been designed to benefit some populations over others. And that's what systemic, and in this case, we're talking about race, right? It's the economic system, the education system, healthcare, criminal justice. These systems are infused with and impacted by the racism in which they were created and maintained. And until we reckon with this, we will continue to have social ills, health issues. Um, our productivity as a nation will not be optimal because people are not well. Pinpointing inequity in the ecosystem. So we know that there's inequity in housing, in neighborhood resources, in education, and in employment. And we also know that we have inequities in healthcare. We have inequities in access to care and treatment. So we are a part of the ecosystem. And again, until we reckon with this, we will continue to see racial trends by hospitalization, preventable hospitalization, readmission rates, late chronic disease diagnoses, premature death, crime and social ills, mental health issues, and lost productivity. Here's a very powerful timeline that I want us to just take all this in for a minute. So if we trace back to 1619, it's 2021 now. If we do the math, approximately 83% of the time period, slavery and segregation were legally sanctioned in this country. That's 83% of the time. I would argue that we're not even in the green zone yet. We're not in the green zone because of voter suppression. We're not in the green zone because of mass incarceration. We're not in the green zone because of Ahmaud Arbery, Breonna Taylor, George Floyd, right? So I'm thinking about this is something that's been published, but I think I want to do another um, revise this to just show that we still aren't we're not in the green space yet, and it takes a long time to undo centuries of damage. We don't overcome this overnight. Extinction does not occur overnight. And so anytime we have inequitable conditions in a society, meaning everyone does not have equal access, then we will naturally see health disparities, which are measurable differences in the incidence, in the prevalence, and mortality and burden of disease and other adverse health conditions that exist in specific groups. That's what happens, right? And so, yes, we want equality, right? We want everybody to have the same thing. But unfortunately, we can't apply that lens because that's just not fair, because everybody didn't start off at the same place. Some people need more resources than others. And that's what equity is all about, adjusting resources according to need. We know that health disparities also cost the country lots of money, right? This study is one of the most referenced studies. They looked at how much this is costing us, and it came up to be $230 billion over a 4-year period. The researchers also estimate that lost productivity, when you calculate that, it's up to $1 trillion in lost productivity. So we're not our best selves as a nation when we have racial inequality. We're just not. And given the changing demographics of the country, it's very important that we address this. So you can look here, you can see this is the vertical axis represents life expectancy, and the horizontal axis represents how much we're spending per capita on healthcare. And you can see that we are all the way over here. We're pretty much off the charts, right? So we are spending a heck of a lot more, almost $9,000 per capita, and our life expectancy is among the lowest. So something's just not right. And this is a big part of it. So let me just very quickly share some of the findings from the report that me and some students did for the mayor in Washington, D.C. To tie all this together. So when we say racial equity, we're talking about, racial equity is achieved when race is no longer a predictor of a health outcome, right? That's the world that we dream of, right? Where you just can't predict a person's race or their health status. You can't predict health status or longevity or life expectancy by looking at race. Right now, we can do that, unfortunately. So one thing that I encourage health systems to do as they go through their planning process, and if they really want to do meaningful work in this space, is to engage a historian. And so anytime I do a community health needs assessment, or if I'm assessing the community, I look for who's the historian of this community, like who knows what happened in this community, you know, 100, 50, 100, 150, 200 years ago. Like what was happening here, or just within the past 50 years, right? Through that, you can really you get a better understanding of the dynamics of a community, and it helps you make sense of why things are the way they are today. And so we work with Maurice Jackson, who's a historian who can tell you just about anything you want to know about the history of DC. So just tell you what, did I share these with you before? These narratives. So one thing that we do in our work is we're always interviewing patients and community members about their healthcare experiences. And we've created these fictitious profiles. So they're fictitious profiles, but the themes are based on what the community and what the people have told us. All right. So this particular um, profile is Otis, and he says they asked me a lot of questions about my pain. I think they assumed I was seeking drugs. Rashida says obesity and diabetes, they run in my family. In the beginning, I felt like my providers thought I was lazy and I didn't care about my health. Sandra, um, my doctor tells me to eat healthy, but it's difficult. The grocery store is far away. The foods I can obtain are not very healthy, but they are affordable. This is my local grocery store. Dwayne, and this is actually a real person here. He's a barber in DC and just a wonderful guy. The people who run these healthcare organizations, they don't look like us. It's a big disconnect. Solomon, I don't connect with anything in my doctor's office, from the pamphlets, the magazines, the team that cares for me. No one looks like me. So these are just some themes. And speaking of this particular profile, I want to share with you what this facility, this hospital did, Brigham and Women's. Um, they actually conducted an environmental scan, and we tell these leaders of organizations, do an environmental scan and make sure that your environment is reflective of the populations that you're serving. And this is one of their first stops, their auditorium. These were pictures that they had hanging of 31 former department chairs, and they were all white males, right? And so what they wanted to do was to address the issue. They removed the portraits. I think what they did was they distributed them throughout the facility, so they weren't all clustered in one place. But they wanted to be sure that they created an environment that was much more reflective of the populations they were serving. So we tell these folks who are leading these organizations, look at the pictures, look at your educational materials. What about the magazines that you have in the waiting area? What does that look like? What's up, right? And then for them to develop a plan based on what they find. But they also need to know their patient population, right? They need to know what percent of population is of this particular demographic, so that they can meet folks where they are. This is Mrs. Jones. We hear this a lot. The District of Columbia, just like many other cities, are undergoing gentrification. And she says, I'm a third generation DC resident. I live alone. My church is now a high income apartment complex. The people in my neighborhood, they're gone. Parking is expensive and sometimes it's just impossible. Although my house is paid off, and we see this a lot. People's homes are paid off, but it's still becoming too expensive for folks to live in the city. And they are also experiencing social disconnection because everything around them has just changed radically. So I earlier mentioned the difference between equality and equity. Here's a visual for you if you haven't seen it before. I think probably those of you who are in community health have seen it. But equality is giving everyone the same, and that's what you see depicted here on the left. The apples are a metaphor for opportunity. So what you see is the height of the boxes is the same. So we have applied an equality model by giving everyone the same thing. But you can see that the need is different because these folks are different heights. And so what we need is to apply an equitable lens in which we adjust this level of support that we're providing based on the height of the character so that all characters have access to opportunity. And that's what equity is all about. So that's how we address the issue, right? Distributing resources according to need. DC is also a very segregated city. This is the map of Washington, DC, and you can see the darker colors. This is where you have predominantly African American, and the far left you go, the more white the communities are, and the more wealthier the communities are, right? So it is a segregated city. The residential segregation index is 68. So out of a zero, zero is a community that is completely integrated. 100 is an index that is completely segregated, and DC is 68. Why is the residential segregation index important? Well, there's a lot that we can infer just based on how segregated a community is. The more segregated a community is, the more likely we're going to see all kinds of things we don't want to see: poor health outcomes, more violence, crime, social ills, and so forth. And then here, again, here's showing again. This has been pointed out, and You can look at who's getting the first dose of the vaccine, and you can see disparities based on where people live. So, you can choose the indicator. What we did was we looked at white residents versus black. We applied a very simple statistical model when we did this. Nothing too complicated. We just wanted to tell the story at a high level. So hypertension 4 times higher, death due to coronary heart disease 2.5 times higher, stroke 2.5 times higher, death due to diabetes 6 times higher. Choose the cancer, and you can see the disparity, right? And then here we looked at wards. So DC has 8 wards. We looked at the vastly different wards, and that would be Ward 8 and Ward 3. And you can see Ward 8 is predominantly black, Ward 3 is predominantly white, and you can see the income is almost 4 times higher in Ward 3 when compared to Ward 8. You can see educational differences. Life expectancy there's a 16-year difference in life expectancy between these two communities. Infant mortality 6 times higher in Ward 8. Cancer 2.5 times higher. That's just all cancers. And then heart disease 4 times higher. So we also provided some recommendations on what to do. And you can take a look at some of our recommendations. But one of the things that we want leaders to do as they think about planning and new ways to do business and innovate is to speak to the people, like literally go into people's homes and go into their communities and be humble and listen, right? And so we facilitate these learning journeys where we take CEOs and board members and physicians and nurses into people's homes and let them just talk about their experience. And it's a very powerful, powerful moment for these folks because a lot of these folks are so far removed from the hardships that people are experiencing, and they take what they learn back into those boardrooms and have different types of conversations around, okay, well, how do we change the system? How do we looking at this, this is a true story. This was her apartment, right? And if I were her doctor or if I were her insurer, it would be in my best interest to help her address this issue. That, my friends, is healthcare. That's what I mean by, are we providing healthcare? Because historically, the way we would treat Shanika is we just keep giving her all her medications and she just keep going home, and this is her lived experience. And then she would probably end up dying early, right? So we have to think much more holistically and build a capacity to understand, if there's something happening in a person's home that's not um, conducive to their livelihood, then we need to be bigger and think better and be more strategic and find ways to fund issues and finance these things. So, to make a long story short, we're seeing more and more medical legal partnerships. And so, this would be a perfect opportunity for a medical legal partnership um, because what you have lawyers, and a lot of times these are law students that will actually, because their management company, no management company should have anyone living in this condition in this country. This is illegal what's happening here. So it's exploitation, right? You have a management company that's taking people's money and not upholding their end of the bargain and creating safe, livable, um, apartments. And so this needs to be called out. And so a lawyer can intervene on this patient's behalf and do what needs to be done to get this patient out of this situation. And so that's bringing in the legal piece into the medical model, which is important. And we know that more and more of these are happening all across the country. COVID mortality, 3 out of 4 people who die in the District of Columbia are Black. That statistic has been consistent since this thing started. Okay. Wait a minute. One moment. Any questions while I get back to where I was? let's see. Oh, okay. The other thing I wanted to be sure I covered is this concept of race. So uh, race is a social construct. It's not real. It's something that we made up. Well, we didn't make it up. People back then made it up, right? And it was created to maintain power, to disenfranchise, to marginalize people of color. The Human Genome Project affirmed this in the 90s, right? Race is a social construct, but we still see practice in which race is a key driver for how a patient is clinically treated. And that is very, very, um, it's dangerous. It's inappropriate, um, and we should know better. But this goes back to my point about we're swimming in a system that's been designed a certain way, and we don't even realize that we're swimming in it. What you see here is a study that was done in 2016. These researchers interviewed med students and residents, and they found these medical fallacies, like black skin is thicker than white. So some of these folks thought that. The other one was people's skin coagulates more quickly than white people. Black people's blood coagulates more quickly than white. These were the two leading medical fallacies that these folks brought to them to med school. What in the world? Like, where did that come from? Well, it came from the history. It came from the way that um, doctors were trained and what the belief systems were during that time period. Again, going back to that timeline, you don't just fix all this overnight. It's been institutionalized, and it takes a lot to undo it. It takes everyone to be a critical thinker. Some people hate to use the language woke, but that's what being this language that we hear now being woke is all about. It's recognizing when this stuff is happening and calling it out, right? And so it's important for us to know this. And this is just, it's 2016 and folks are still having this belief system still exists. And even, we hear med students talk to us. They come to those of us who do this work and they say, I was in a case, we were doing a case study and my professor said, use, race as a key indicator for making a decision about a person's next steps in their treatment protocol. And what we challenge our students to do is to push back, because it's not about being black, it's about the way that the system has created conditions for black and brown people that put them at an increased risk for um, sickness and premature death. So that's what it is. So and COVID is showing us this, right? We're seeing higher rates of hospitalization, higher rates of death in black and brown people. It's not because of a biological reason, it's because of the environment. So yeah, so this work is heavy. It requires introspection, it requires reflection, it requires cultural humility, shifting the power dynamic, um, and it must be integrated as part of a long-term strategy. And we should learn to apply a racial equity lens in key decisions, meaning that if we are going to invest in this particular project or whatever, will it disenfranchise a population? If this decision will disenfranchise or marginalize a population, then it doesn't pass the test. And we have to go back to the drawing board and fix some things, right? So we are encouraging all leaders of institutions, even governments, to apply a racial equity lens and how they do their work, and just to make sure we don't continue to perpetuate the problem. Okay. Any questions? Any aha moments? Is this stuff that you've heard before? Like what did I share anything that's new tonight? Talk to me. What's up?
I had no idea about the study about the implicit. I don't know I don't know what it's implicit bias or whatever about the fallacies.
Oh, the
Like
medical fallacies.
that was mind blowing. On I've never heard of that.
Yeah. All of those fallacies were taught um, centuries ago. That was the belief system back then. And that was people of color's orientation to the healthcare system. And so now it should not be rocket science, right? To realize why people of color are not first to stand in line for the COVID-19 vaccine because of the distrust. And I didn't even share my full slide deck with you. We have the Tuskegee study. We have the James Merriam Sims, who's celebrated in the medical literature as the father of modern gynecology, and he used slaves to perfect the treatment protocol for vaginal fistulas. Anarcha, Betsy, and Lucy were the three that are most mentioned in the literature. Henrietta Lacks, right? And so, I mean, I remember my grandmother will be 100 years old this June, and I always call her my best history teacher. I remember as a child being told about these studies. I remember my uncles talking amongst themselves about the healthcare system and how evil it is and how it's not their friend. I remember those conversations as a young boy. I wasn't part of they were grown and I was a kid, so I didn't partake, but I just remember hearing them talk about healthcare and doctors and black people and how you always have to, watch your back. Um, and it still exists today, that mindset. So we have to do a better job as an industry, right? We have to fix the problem, recognize that the industry has been part of the problem, and do everything we can um, to address it. That includes having a different type of way of interacting with patients and community members. Community engagement is key. What does that look like, right? So that the barber that you saw, Dwayne, um, sorry, did I tell you all about the barbershop program? Okay, good. I speak to so many different audiences, and I don't want to rehash stories because that really doesn't make for good instruction. But anyway, so that gentleman that you saw, Dwayne, I'm going to give you just a quick example of the shift in power and what that looks like. He's a barber in DC. We conducted our community health needs assessment, and black men and hypertension, I mean, the off the charts as far as the rates, and we really wanted to do something about it. And so I was a VP at MedStar, and I was thinking about what is our signature program, what's our corporate signature program going to be for community health. And we decided we want to target Black men in certain zip codes in the District of Columbia. And um, the leadership just had this perception that, well, let's just go set something up in the community and people will come. And I was like, nope, that's not what we're doing. That's not how this works. That is not how this works. We don't just show up and take credit and use the community. And that was the feel that I was getting from folks in leadership, even though they didn't say it exactly like that. Um, and it was also like, this could make for a good press release. I was getting that a lot. Um, and that's what people of color are very sensitive to because they know that they've been used, especially go to Johns Hopkins and speak to the folks who live in that community. I mean, those folks are not fans of that university because of the history. Researchers have asked questions and did all kinds of studies on people, and they don't get anything in return. And that's a major no-no, right? If you're going to engage, if you're trying to study a population, you have to give them something in return. The least you can do is let them know the results of your study, right? But a lot of times they go, they get what they need, they publish, and they get these publications in these esteemed journals, and they get all the recognition. They tell the story of what's happening in these communities, and the community's left with nothing, no benefit. And so that was one of the first lessons I had to help the leaders in our system understand, shifting the power. And so what we needed to do was needed to find who are the communities, who are the leaders in those wards, those zip codes, and who wants to take a lead in doing this work. And we found Dwayne. And he says, you know, he said, Christopher, I've been in this community for 25 years, and I can't tell you how many funerals I've attended, folks whose hair I've cut over the years. They lost their lives due to diabetes or uncontrolled diabetes or hypertension or heart attack, stroke. I want to do something. That's what Dwayne approached us. He said, I would like to outfit my barber shop into a health hub. They're like, oh, that's interesting. He's like, I want every person's hair that I cut and my team, I want us to be able to take their blood pressure. Can we do that? I'm not a doctor, I'm a nurse. Can we do that? And we say, yeah, we can figure out a way to make that happen. So this man, someone who's well respected in the community, he's been there for 25 years. He's solid. He has his own barbershop, outfitted with support from us because we had some federal funding, some funding from a drug company actually. And what we were able to do was to let him choose what he wanted to display in his barbershop. So he had really cool videos, pamphlets, educational materials. It was a place to go um, for a healthy living. That's what I mean when I say shifting the power. That was his creation. We supported the work. We were behind the scenes. We trained the barbers on how to do the blood pressure screenings. We trained the barbers on, how do you have a conversation about health and well-being or fatherhood. I mean, everything that was discussed in that barbershop had a health lens to it. And that's the type of environment that he cultivated over time. And it was a beautiful thing. It was a beautiful thing. And we learned in our analyses, our evaluation, that these men were having, um, someone put something in the chat. I want to make sure I didn't miss anything. Did someone say something in the chat?
Oh, I
Yeah.
just said it's amazing.
Oh, okay, Marina.
Story.
Thank
Thank you
you.
for sharing.
Oh, yeah, no problem. So, oh gosh, train of thought gone. Yeah, anyway, good thing. I'm so happy that we were able to work with Dwayne. But let me tell you one other thing about this story that moved me to tears. And every time I tell this story, I still get choked up. It was such a wonderful thing that he was doing for his community that I wanted him to come to our board meeting and tell the story because it would make a much more meaningful, it'd be a much more impactful arrangement for him to tell the story than for me to tell the story. And let me tell you, what do you think he said when I asked him to come to the boardroom in Columbia, by the way? I want you to come to one of our board meetings and talk a little bit about the program. What do you think his knee-jerk reaction was? Just guess.
Did he say no?
Why? He did say no. Why?
I mean, I would say no. That's kind of like that's scary. Just a normal person with like a bunch of executives. That's just like how I would think.
And that's exactly what he said. but he was a lot more raw and explicit in his language. Um, those educated people, they're not. They're. I don't even have a suit. He's like, I don't have a suit. I'm not educated. Basically, he was minimizing himself and pretty much suggesting that he's not worthy. And that really, it didn't surprise me, but it made me very sad because he feels that they're up there in their fancy suits and doing fancy things, and he's just cutting hair and trying to make ends meet for him and his family. He told me no, and over a few months, I kept asking him over time, and he finally obliged. And he's like, but I don't have a suit. And I was like, I don't want you to wear a suit. I want you to come as you are. Don't change the way you speak. Don't code switch. That's not what we're doing. Be who you are. That's what makes you so amazing. And he came and he told his story. He was a little nervous, but once he started talking, he got over it. And the board was very impressed with the story that he told and the impact that it was making on the community. He goes back into the community and he tells all the people that come to his shop about the experience. You would think he visited the White House. It was such a big deal for him. So just that alone tells you that we have some issues. We have some issues. And the more and more people that I've interviewed, people of color, particularly people in historically marginalized communities of color, it's an us versus them dynamic. Those people, they don't care about us. They're going to use us. They're going to exploit us. They're going to conduct research on us without our consent. It's 2021, and that's the mindset because we as an industry have not stepped up our game. And I'm just hoping that what happened in this country over the past 4 years was enough. I'm hoping that what happened on January 6th was enough, that we have to do something about this. So, anything else? Did anything else stand out for you? No? So you'd heard all this before.
I think for me, it was just the timeline of seeing it visually
Yeah,
represented how long.
yeah,
I mean, you
yeah,
know that if Martin Luther King was still alive, he would still be alive to this day. So you know those people who did horrible things to him, to the Black community,
yeah.
they're all still alive.
They're still alive, yeah.
So
And their grandparents, right? Their
and their
grandparents and
their
and
kids as well. Yeah.
yep.
I also thought it was interesting just how a lot of with these fallacies in particular, how even though they've obviously are untrue and research has shown that they're untrue, it's still shown to be like done and implied in medical schools and how they're practiced. So in a sense, like I just think of like providers still learning these um, implied fallacies and kind of like using them in their practice, and that kind of scares me when I think about it.
Yeah.
And even just like the fact that in textbooks they don't have like um, other colors like darker skin toned people, so you don't really know how it might look when a particular person of color might become infected with something or just get sick. It just shows the danger in that as well.
Yeah. 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 And so, you know, we need to at some point remove race. I mean, we still need to collect data on race, so don't get me wrong, I'm not minimizing it, but we need to remove race and we need to look at ancestry and we need to look at the environment, right? Just like we know with sickle cell, right? All that is based on the environment. It's not because you are black, it's because of where you grew up in the world. And so it's important for us as an industry to recognize that. We still need to collect data on race and ethnicity because that's important for us, so that we know where resources need to be allocated and so forth. Just like with COVID, like, right, we need to know what racial groups are getting vaccinated. That allows us to determine where we want to put more resources and time and energy. So it's still important, but we need to be much more sophisticated in how we are um, 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 obtaining information about a patient and applying a much more holistic lens and determining what's necessary to keep to improve this patient's health or keep that patient well. Okay. So now what I want to do is go into implicit bias. How many of you have had any type of training or any instruction on implicit bias? You have. Okay, tell me what you know, Austin and Keshel. What do you know?
So, I mean, I know that essentially it's just essentially biases that we make that we're unaware of. In terms of like application, I took a class, a philosophy class, where we had to take like, they're like online tests you can take that have
Yeah.
like images that assess your, I guess, your level of implicit bias. But
Right.
that's
Where was this again?
this was an undergraduate at the University of Maryland.
Okay. Okay.
Similar to Austin, I actually took it for classes for my current program. We did a implicit bias test, and we also wrote an essay based off of like our implicit biases.
Okay.
We just kind of learned, or implicit biases are just, like our initial judgments, like our snapshot judgments of,
Right.
people. And
Right.
it's not necessarily like a good or bad thing. It's just, the judgment that we make initially.
Right. Right. Okay, good. Good. Anyone else? Okay, so I'll depend on Austin and Keshel to chime in as I go through these slides. Okay. So what is implicit bias? I'll cover that. How does it show up in clinical care, interpersonal interactions, and management decision making? And then, what are your biases? And your assignment between now and next week is to actually take the implicit association tests, and the link is in Canvas for you. There's about 13 different modules that you can choose from. Choose the one that speaks most to you, but we'll talk about that at the end of class. And then what can you do about it? So I think to kick us off, I have a video. So you can move me.
Are you seriously considering her as a candidate?
Just don't trust
She's a
her.
woman.
She's a
This is a
woman.
man's job. She's clearly not educated.
Hey, does she even speak English?
That's not me. I'm not like that. You call it an honest mistake. Science calls it a blind spot. Our unconscious mind is a mysterious and powerful thing. It makes 90% of our decisions without us even knowing it. Our brains are overloaded with 11 million pieces of information every second. Yet we can only process about 40 of them. So we're wired to make cognitive shortcuts, using past experiences to make assumptions. And you know what happens when we assume? Our unconscious mind can put us on autopilot, determining where we sit, who we eat lunch with, who we turn to for advice, and who we choose to offer a helping hand. Living our lives with blind spots can put us in a tunnel. Same point of view, same decisions, same outcomes. We can find ourselves trapped in the land of snap judgments and misconceptions. We've all been on both the giving and receiving end of blind spots. Think about it. Who's talented? Who's able? Who can I trust? Who belongs? We've all been there. Blind spots are part of the human condition. Our choices have consequences for us and the people we interact with. By accepting that blind spots exist, we can stop. Imagine what possibilities exist if we could do it all over again. Different perspectives, inclusive relationships, diverse networks, better outcomes, seeing people for who they really are. People like you with unlimited potential. We all have blind spots. Once you accept that you have them, you can choose to do something about it. It's time to check your blind spots and focus on what's possible.
I think they did a pretty good job with that. Okay, so it's pretty simple, right? Just as you heard, we are a product of our environment, and we've all been born into a system that is riddled with injustice, a system that has painted pictures for us of what is perceived to be pretty and ugly, safe versus threatening, um, um, good versus bad. What's his profession? What do you think his profession is?
I'd say maybe an author
An
or
author?
like a writer.
A writer? Okay. Anyone else? Just brainstorming.
Maybe something with IT or anything like that.
IT? Okay.
A journalist, maybe?
Journalists? He's a nurse. He's a nurse. And so operating room nurse, former lumber mill worker, right? So we could probably see that, right? But operating room nurse, right? So he does not fit our mental model, right, of a nurse. That's what mental models are, right? The way that our brain has been, you know, we put things in boxes and categories, and anything that's outside of that is an anomaly in our brains, right? And we don't pick up on it. That's why no one said this gentleman is a nurse or could be a nurse. And so implicit bias, these are attitudes, stereotypes that affect our understanding, our actions, and our decisions, just as you've heard earlier, in an unconscious manner. That is the operative word. We have no idea that we're doing it. If we know that we're doing it, that's explicit. That's perhaps discrimination, right? We know it's happening. But sometimes it happens, implicit bias happens, or discrimination is happening, and we have no idea that we're doing it. That's implicit, that's unconscious. It's not accessible via introspection, so we can't even articulate it when it's happening. So how does it work? Our brain is constantly bombarded by stimuli, right? There's always, even right now, there's so much that's happening, right? You're listening to me, you're reading the screen, there may be something happen, Marina, I see your daughter, or is that your child coming in and out, right? There's a lot that our brain is processing at any given moment, and scientists estimate that there's 11 million pieces of information at any given time, but we can only process about 40. So everything else relies on neural pathways that have already been established based on your history. And that's when your automated process steps in and you have decisions and do things that you're not aware of. Your brain is on autopilot. The brain takes mental shortcuts and relies on pre-established neural pathways based on how the world has shaped our perceptions. And it all starts from the beginning, right? You know, clean slate. I would say that these babies have already been impacted because they're toddlers. This stuff happens soon as the child is born, right? Soon as the child is born, we know that baby boys are socialized. In many cases, things are changing now, but historically, baby boys have been socialized differently than baby girls, right? And so we're already starting with this process soon as the child comes out of the womb. Society sends us these implicit and explicit messages around what's good and what's bad, what's pretty, what's ugly, what's strong, what's weak, what's normal, what's abnormal. Again, this is the kid going home. And you see that we are putting all kinds of expectations and we're socializing the child a certain way. We know that we're more likely to, our biases are more likely to show up when we are in a stressful moment when we have time constraints, when we're multitasking, when we have a need for closure. And so that's why this is such a risk. I teach a quality course in healthcare, and we know that it's a high stress environment, healthcare. And so if I'm telling you that environments like this are the types of environments where biases are likely to show up, we are a very, very susceptible industry. And so when biases show up, when we're making a decision about a patient just based on a skin tone, then we could be making a mistake. So it's important to note that when we talk about implicit bias, we're not talking about racism, we're not talking about sexism, we're not talking about misogyny, homophobia, xenophobia. Those are very explicit manifestations, right? We're talking about things that happen, decisions, perceptions that are occurring that we have, and we have no idea that we're doing it. They may be rooted in racism, they may have stemmed from racism or sexism or misogyny or homophobia or whatever, but it's the world has done such damage on us that we have no idea that we are governing ourselves a certain way. And that's what this implicit bias is. Now, it's a good thing too, right? We need this. I think, Keisho, you were saying we need this. This is our brain's way of surviving, right? Think about, how many of you've driven to work, or you went to the store and you get to that location and you have no recollection of the experience getting from A to B. You don't even remember it. You're like, I got here somehow, I don't remember. Right? That's you going into auto mode. Your brain just took over for you, autopilot. You probably were thinking about other things, but you got to your destination safely. So it's a good thing, right? These neural pathways that have been developed. Um, but we have to catch ourselves because sometimes we can make really bad choices and do bad things and say bad things. Implicit bias is a normal part of the human experience. Biases may not be aligned with our declared beliefs. We do have a preference. Normally, it's very normal for us to gravitate towards people, persons, or things that have some familiarity. So I tell my students who are trying to be better citizens of the world, better global citizens, right? If you go to a conference and you have a choice as to where you sit, try and find some people or a setting that's unfamiliar to you and not allow your brain to go into auto mode, because what you're naturally going to do is find someone that gives you some sense of identity, right? Someone who reminds you of your own identity, whether it be your age, your gender, your appearance, right? We naturally gravitate to those people. It's part of the human condition, but we know better. We can interfere on those tendencies. So look at these examples I want to share with you. This also costs corporations lots of money um, when they're doing things. Sometimes this may be outright racism, but I would like to hear your perception, your thoughts on this. This is the doctor who was on a plane a few years ago, October 2016, Dr. Tamika Cross, and a patient was having um, a medical a medical issue. I think it was a heart attack, and the flight attendants asked if there was a doctor on the flight, and she said, "I'm a doctor," and they just totally dismissed her. They totally dismissed her. Um, what do you think? What happened there? What do you think that was? Do you think that was just racism? Do you think it was implicit bias? What do you think? It's hard to say because we weren't there, but just by what I'm telling you, what do you think happened? Break this situation down.
Personally, I think it was an example of implicit bias because people probably assumed that she couldn't be a doctor. Like, there's no way that she could be a doctor. Um, I don't know if it was racism per se, but they're like, oh, she can't be a doctor, or like they didn't even like attempt to hear her. Maybe she wasn't loud enough, or it's like there's no way that she could, you know. So I think it's an example of implicit bias.
Okay. Anyone
Um,
else?
I agree. I think that there's like a lot that kind of plays into it. I think that's more an example of implicit bias. One, because people don't necessarily think that women can be doctors, but also her being a Black woman, you know, there's a lot that kind of plays into that. So I think that with that, it, you know, just with the situation, there's a lot going on.
Yeah.
They're probably assuming, you know, that
Right.
can't be the case.
Right. And that's why it's so important to be enlightened, right? And that's why it's so important to have diversity. And so what Delta did in response was they, looked at how they're training people and how they respond and when they have situations like this. They learned their lesson, hopefully. I'm sure there'll probably be another event at some point, but it was a major issue for Delta. Um, and what we have to do is just get out and see the world, and you would think that that wouldn't be the case because that's what they're doing. They're seeing the world. They're flight attendants, right? They're all over the place, but this still happened.
Sir, I have a question.
Yes.
So it said changes policy. What policy was changed? Do you know?
Oh, block from where do you see it changed policy?
Delta apologizes, changes policy.
Oh, changes policy. I'm not sure. I'm not sure
Okay.
what the policy was. I'm not sure. I should probably look at that. I'm not sure what the policy was that they changed. Okay. And then you're probably familiar with the H&M debacle where they put this child, coolest monkey in the jungle. I mean, how did this even get through marketing? Well, I'll tell you, they didn't have a diverse marketing team, right? So companies pay for ignorance and stupidity. Was this intentional? I don't know. But it should not have gotten through the process. Should have been stopped at first base. And then this one, you're probably familiar with the Starbucks, issue with the black gentlemen who were in there, and they were asked to leave, and they were arrested because they like, why do I have to leave? Like, what are we doing wrong? We're just sitting here. And then Dove, this is their summer glow. It says nourishing lotion for normal to dark skin. For normal to dark skin. So I don't think that this was a racist thing, this particular example here. I think this goes back to, again, when I say we are all swimming in a system that is riddled with all kinds of craziness, we just become accustomed to it. And especially if you are not a person of color, you totally miss this, right? And so I'm not saying you all will totally miss it, but folks are likely to miss it if they are not a person of color. So nourishing lotion for normal to dark skin. And then this is a gentleman that was on, oh gosh, this wasn't too long ago. His wife came home, they had a newborn child. He's going out for a run and he's pulled over by the cops because they're looking for another black male for some reason. I'm not sure what it was, but it also made the news. These are just examples. This stuff happens every day. For us, racial bias in hiring is real. If you're not familiar with the Emily and Greg and Lakeisha and Jamal research that was done, this was in 2004, but it is one of the most frequently cited investigations on this topic, but what they did was um, they put out these resumes, um, and the only thing that was different was the names. And so Lakeisha and Jamal were less likely to receive a callback when compared to the resumes that had Emily and Greg. So we know that bias occurs just by a person's name. And some organizations are even wiping away addresses because people may have a tendency to have a perception about a person based on where they live. Weight bias is real. In this study, they looked at med students from 49 medical schools, and they found that 74% exhibited implicit weight bias, meaning that they think that people who are overweight are less likely to be motivated, or less likely to care about their health, are more likely to be lazy, right? Those were the metrics that they looked at. And then, but get this, 67% were explicit about it. Like they said, this is the truth. Like they believed it. So this is real. And people, overweight and obese people have also a very difficult relationship with the institution of healthcare. We have not um, we have not done that population well, and we need to continue to work on that. So you see that guy right there? This is my story. I'll share this with you very quickly. This is my team. We were working at MedStar Washington Hospital Center, and we were the philanthropy team. And so we planned it was a 50th anniversary for the hospital. So we planned an annual gala, a big gala, 50th anniversary gala at the Building Museum, the Washington Building Museum downtown. Anyone who's has heavy pockets was at this event, right? Deep pockets was at this event. And it was very, very nice, very magical. And I was one of the hosts. We are the ones that put this event together. So, you're looking around and you're seeing all these wealthy, affluent people schmoozing and having a good time. You could count the number of black males on maybe one hand, but you couldn't count the number of black males in the kitchen on one hand. You needed about 5 to 10 hands to do that. Okay. So I can't tell you how many times these folks who didn't know me at this event would pull me to the side and ask me, can I get another glass of tea? Can I get some more bread? I got that so frequently, and it became emotionally taxing to continue to deal with that. And I'll never forget one lady. She asked me if I could bring her another cup of coffee, refill her coffee. And I told her who I was, and she looked at me and she just imploded. She just felt so bad. She was like, "I'm so sorry." And I could tell it was very authentic. And and this was early in the evening, and then while she was leaving, it was like midnight. I saw her from a distance and she was leaving. I guess it was with her husband. And we were about maybe 15 feet away from each other. So we weren't in a space where we could just talk to each other. But but she as she walked out, she looked at me and she said, I read her lips. She said she was sorry. And that was a very moving moment. That was a very moving moment. It was a very educational moment for me. It was an enlightening moment for me. And it helped me understand the other side. When people are like this woman, affluent, she's always in the company of people who are affluent and is probably accustomed to having the help be a person of color. So she made an assumption. It was a bias, right? She didn't realize what she was doing. But that decision that she made to ask me for to refill her coffee was based on what she'd seen in during this event. You know, most of the folks who were filling coffee look like me. So it helps me just knowing that, and that's why education is so important, right? I understand this, and I could just get angry and say racist, 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 and be a bitter man. But fortunately, I've been educated, and I can step into someone else's shoes and use this as a teachable moment to enlighten them. Now, if racism does show up at my doorstep, I'm ready for that too, right? If the explicit manifestation of racism shows up, I'm ready for that too. But in most cases, again, I think people wake up and they really want to put their best foot forward, and they just fall prey to, again, the world and how unjust the world is, and they hurt people in the process. So the IET is what I want you to take after class or at some point between now and next week. It measures the strength of associations between concepts, and it's measuring the time it's taking you to make a decision. So you'll get these images that pop up, and then you have to make some decisions, and you'll get an output, and it'll tell you how you fare compared to other folks who actually took that same module. And so this one, you can see this one says percent of web respondents with each score. So this is if you're looking at, oh, this is okay. So this is for everybody that's taken the IET. What they're saying is that 27% of people who take it have an automatic preference for white people compared to black people. Another 27% have an automatic preference for white people compared to black people. Okay, so the majority, more than 50%. No, is that? Yeah, that's more than 50. Yeah, that's more than 50% of folks have either a moderate or strong preference for white people. So this is all out of all the folks who've taken it. Okay. Oh, and this is a 16% slight automatic preference for white people when compared to black people. Again, this is the module on race, but you can do one on weight, you can do one on careers, you can do one on presidents, which is a fascinating one. You can do one on religion. Like, do you have a bias towards a certain religion? You can do one on LGBTQ. Um, uh, they really expanded the types of modules that are available for folks. And then this is the book I would recommend. It's called The Blind Spot. It was written by the creators of the IET. Okay, exercise for you. This next slide is going to stay up for 5 seconds. And what I want you to do is I want you to count the number of F's in the sentence. Okay? Are you ready? You're just going to count the number of F's as in Frank. Go. Stop. How many did you count? You said 5?
6.
You said 6? 7? So I have 5, 6, and 7. Okay. So here we are. How many of you got 6? Okay. Okay. So one thing that we know that what's susceptible to being left out is the ofs. And it has something to do. I'm not a neuroscientist like that. But I know that they were saying it has something to do with the ofs and the way that I don't know. I'm not even going to start lying. But my point is things can be hidden, right? If we're not mindful. And so it's important for us to stop and really focus, because if not, we'll have these blind spots that occur. Here's another one. In this next slide, you're going to see a series of 25 words in different colors. I want you to say the word you see and go as quickly as you can. So you're just going to say the color of the word that you see as if you were reading a book, okay? Say the color of the word as you see it to yourself. Okay, good. Not too difficult, right? That was easy. Okay, so now in this next slide, you're going to see the same um, similar set of words in the same format. In this case, do not read the words. Instead, say the color in which the word appears. So you're not reading it, you're just saying the color in which the word appears, and go as quickly as you can. Okay, let's just stop here. Okay, so talk to me about this exercise, test B. This totally destroyed your mental model, right? The neural pathway had to find a new direction, right? So what happened? How did you do?
Um, this one was more difficult because the actual color didn't align with the word. So I had to like manually like look at the color and say the actual color. So I adjusted, but it wasn't as easy as test A.
Right. You had to really spend some time on each word, right? You had to think about it. And that goes back to the whole, that's why we're doing this exercise right now, because um, that's how implicit bias works, right? So we're making these decisions and we have no idea that we're doing this. But if we want to mitigate the risk of making a poor decision, then we need to stop and focus and not just let the neural pathways, you know, uh, be our default, right? We really need to stop and focus and be attentive to what's happening to get it right. So it took a little more time to do this. Sometimes it takes more time. Let's see. Okay. Okay, so I think that's it. That's all I wanted to share with you. So when you go to the IET, let me just take you there really quickly, just in case you have any questions. Okay, so yeah. So you go down to March 2nd. It's going to be in tonight's class. Assignment for next week, take the IAT. So you just click here. It'll take you directly to the website. And all you need to do, because folks get hung up here, is you don't need to put in an email address if you choose not to. That's perfectly up to you. You could just click go and it takes you directly there, right? You can read the disclaimer, you wish to proceed, and look at all these different options: president, race, gender, career, religion, disability, sexuality, weight, skin tone, weapons, age, Arab, Muslim, Asian, transgender, gender science, and there's a description of what it's actually about. So just choose one. You know, Austin and Keishel, you've done this before, so choose one that maybe you haven't done, or if you want to do the one that you did, then do it again. Um, I will say that this is the best on the market. This is the only tool that's most frequently used in the industry. But I will be fully transparent and say that it does have its experts debate about the validity and the reliability of the instrument, because if you take it now and you take it in 30 minutes, there's going to be quite a bit of variation in your output. And so when you see that a researcher will naturally question, you know, validity and reliability of the tool. Um, so just know that. But go through the process, see how it feels when you have to make those choices. And if you're having a hard time, that's probably an indicator that you're dealing with some issues. Okay. And that's okay. That's okay. That's why we're doing this work, just to bring awareness to these issues. And then I want you to just think about when you get your output, and please don't take it a million times. Just do it one time. Be focused. Do the best you can. Don't try and outsmart the system. Just just do it, right? And see what your output is. And then I want you to just, you know, it's personal, so I'm not going to ask anyone to share unless you feel like it, right? I encourage you to share because this is the space for learning and it's okay. And if someone has something that they're very disappointed in, that's part of what this class is intended. That's part of what this whole experience is about. It's about reckoning with ways that we may think or things we may believe, and using this as a vehicle for talking about it in a space that's professionally facilitated, right? Where it's all part of what the intent is to make sure that our students are growing personally and professionally and academically. So, okay. So you don't have to submit anything. I'm just going to trust that you are taking the IIT, and hopefully a few of you will be willing to talk a little bit about your experience with taking it and your reflections, and what are you doing now? What are your next steps? Okay. All right, so we can stop there unless you have something else you want to talk about.
I have one question, Dr.
Yes.
King.
Yes.
Do we have an exam coming up? Because I think I might have
Yes.
seen something on either the syllabus or ELMS,
Yes.
and I was wondering if you would just touch on that like a little bit. I'm pulling it up. I forget
Yeah.
what date I saw.
Let me go to the syllabus and be sure that we cover that. Sorry, give me one moment. It's somewhere down here. Okay, here we go. All right. Okay, so I have it for the week of March 9th. So, okay. So we don't have class next week. Okay, so look, this is what we're going to do. I am going to send you a study guide, and I will open the exam from the 7th through the 14th, and you take it anytime during that time period. Okay. But I will send you a study guide. And then if you have questions based on the study guide, email me. Let's talk about it. But it'll be pretty self-explanatory. The exam will be administered via Canvas, and it'll be time-based, so it's about 60 minutes. True, false, multiple choice, short answer. Okay. Follow the study guide. Follow the study guide. Follow the study guide. Hint, hint, hint. Okay. And then I think the week after that is spring break, right? Yeah.
Mhm.
Yikes. So this means that we're not going to see each other for 2 weeks.
What date did you say the exam would be open? So are we coming to class on the 9th?
No, no, you do not come to class on the 9th. Unless you all want me to do a mini session to prepare you for the exam, then we can meet on the 9th for about 30 minutes. But you would still have to take it, so your window is a little shorter. So the exam wouldn't be open until after we finish our study session. So you'd have from Tuesday until Sunday to take it at a time that's convenient for you. What would you like?
That would be helpful.
Okay. So I'll still send you the study guide in advance. And then we will have an abbreviated class next week. And this will be your opportunity to ask me any questions or for me to clarify any content. Cool? I think that's a good plan. I feel good about that. Okay. All right. So we'll stop here. I wish you all a good night. Okay.
Bye,
Enjoy the
David.
rest of your
Yep,
week.
good night.
Okay.
Thanks.
Bye-bye.
Good night.
Thank you.
Bye.
Okay. Bye-bye.
Thank you, Lucille.